Good evening, everybody. Welcome to this evening episode of Pursue. And today we have Pursue 4A, which is the first of the series of lecture in GYN. And we are streaming live from Kolkata. And with us, we have a very special person to take these lectures. We have Colonel Tanushri Mukherjee. She is a postgraduate from the prestigious Armed Force Medical College, Pune, a DNB, MNAMS, and she's trained in Oncopathology from Tata Memorial Hospital and an affiliate member from the Royal College of Pathologists, London. She'll be talking today on vulva and vagina, the neoplastic lesions, the non-neoplastic lesions, specimen handling, grossing, immunohistochemistry, and updates. It's a long list of things which she'll be addressing today. So before I ask Colonel Mukherjee to take over, let me request all of you to please keep your mic muted, please keep your camera off, and please don't share your screen. When you log in with join now, and don't press present now. With this, let me request Colonel Mukherjee, ma'am, please take over and please share your screen. Thank you so much.
Thank you. Good evening, everyone. Good evening, everyone.
We can see your screen coming. Please make it full screen, please.
Yes.
Please start.
So today I will be dealing with the neoplastic and non-neoplastic lesions of vulva and vagina. The contents will be like this: the development and anatomy, vulvovaginal infections, the non-infectious dermatosis of the vulva, cysts and the non-neoplastic glandular lesions, the mesenchymal lesions, some adnexal tumors, then the glandular neoplasms, melanocytic lesions, precursors of the vulvovaginal squamous cell carcinoma, and the squamous cell carcinoma and basal cell carcinoma. And some topic I will be dealing in detail because it's a quite extensive thing, and so I can't touch upon all the things, but I will be dealing in quite detail about some of the topics. Vulva is immediately external to vagina. It is composed of the mons pubis, clitoris, labia minora, labia majora, vulvar vestibule, and various glands. The Bartholin gland, it corresponds to the vulvourethral glands in males. Clitoris, it is a erectile tissue similar to the corpora cavernosa of penis. Labia minora consists of two folds of connective tissue which contain little or no adipose tissue. Then hymen, which is a non-keratinized stratified squamous epithelium. Then labia majora, which form the lateral boundaries of the vulva, which composed of folds of adipose and fibrous tissue. The vestibule, the area between the hymen and heart line, lined by non-keratinized squamous epithelium. Structures found in vestibule include the major vestibular glands like Bartholin gland, minor glands, periadactyl glands, and urethra. And there are the various kinds of glands: the apocrine, the sweat glands, eccrine glands, sebaceous glands, and the Steen glands. Then vagina, it extends from vulva to uterine cervix, derived from the paired Mullerian duct. There are various layers like the mucosa, muscularis, and adventitia. In the lymphatic drainage, the external iliac nodes, deep pelvic, rectal, and aortic nodes, interiliac nodes, also inferior gluteal and femoral. So, starting with the pathology, the Bartholin cyst, very common due to blockage of ducts exiting the Bartholin gland due to various infectious agents like chlamydia, E. coli. It may occur secondary to some infection, very painful, seen in all ages, but often women aged 40 years. It may have mucosal-like changes. Treatment is vascularization, but if in older women there is risk of adenoid cystic carcinoma, so it is better to do a excision. It is composed of squamous and urothelial epithelium, but somehow the epithelium may be destroyed by inflammatory infiltrate, and it can also have calcification resembling malakoplakia. And there are various infectious lesions of the vulva and vagina, like in secondary syphilis and tertiary syphilis. In secondary syphilis, there is psoriform epidermal hyperplasia with confluent parakeratotic crust and numerous plasma cells. Then, in tertiary syphilis, there is end arthritis obliterans and necrotizing granulomatous inflammation. This is caused, as you know, by Treponema pallidum, which is demonstrated by Wadin starry silver stain, which is shown below. Then the next image is of a chancroid caused by Haemophilus ducreyi. There is an ulcer with superficial necrotic debris, and another image is a school of fish appearance, as you can see in circles, which are the coccovacillae. Then bacterial vaginosis, characterized by the superficial squamous epithelial cells covered by coccobacilli, is the clue cells, and there is a Bartholin duct cyst. Then another image which is showing the herpes simplex virus infection with inclusions, and it can cause a pseudo-lymphomatous response. This image is showing a vulvovaginal candidiasis, the Path stain which is highlighting the pseudohyphae. Another image showing the pear-shaped organism Trichomonas, and the image below showing Sarcopsis trabeae mice. Then there is Schistosoma hematobium ova within a dermal granuloma, Enterobius vermicularis, then amoebiasis highlighted by Path stain, and the cytomegalovirus infection, owl-eye inclusion, very characteristic. And another image showing the molluscum contagiosum, as you can make out, the pseudolymphomatous inflammatory reaction to degenerate dermal molluscum body. In another image, this is showing a papillonecrotic tuberculate in a case of lichen scrofullosorum, non-necrotizing perifollicular granulomatous inflammation. Then Cryptococcus, this is a gelatinous appearance, which is highlighted by Elchian blue and Fontana meson positive cells. Second entity, the non-infectious dermatosis. This is just to highlight curtsy. There's a curved Chabot node, lichen sclerosus, lichen simplex chronicus, very common. Lichen sclerosus, commonly called as lichen sclerosus atrophicus. It causes pruritus, pain, and typical tissue papier appearance. There is sclerosis of papillary dermis and atrophy of the overlying epithelium. This has got increased risk of differentiated vulvar intraepithelial neoplasia. Then lichen simplex chronicus, non-specific pattern in response to chronic rubbing, can be seen in association with other disorders. There is marked hyperkeratosis, hypergranulosis, and irregular epidermal hyperplasia. If you see neutrophils in the stratum corneum, then there is a suspect fungal infection and Path GMS has to be done. So, lichen sclerosus, this is a common condition not to be missed. Early changes are often subtle, associated with thickening of the epidermis, very focal interface dermatitis with hydropic degeneration of the basal cells. And lichen simplex chronicus, I said earlier, prominent psoriform hyperplasia of the epidermis with compact hyperkeratosis and hypergranulosis. The fibrosis of the papillary dermis manifested as vertically oriented collagen bundles. Then it can mimic T-cell lymphoma or mycosis fungoides. And another image is of lichen planus, in which we see the band-like lymphomononuclear infiltrate with hydrophic degeneration of basal cells with colloid bodies or pivot bodies. Then Behçet's disease, which shows ulcer with granulation tissue, and bullous pemphigoid, eosinophil-rich subepidermal blister. Then pemphigus, as it occurs in the skin, common condition, early lesion with acantholysis and tombstone. Then there are various mesenchymal lesions. The entities are many. I will try to touch upon the somewhat which are very common and which can be asked in slides as well as in exams. The fibroepithelial stromal polyp, polypoidal growth, fibrovascular core covered in squamous epithelium, and there's a massive vulvar edema and aggressive angiomyxoma. Papilloma, like it's a Mullerian papilloma or a mesonephric papilloma, benign polypoidal lesion, IHC not required, but like now it is like very much mandatory to ask the IHCs and do it. CK7, CA125 are the positive stains, negative stain CK20, CEA. Then fibroepithelial polyp, composed of central core of fibrous tissue containing irregular shaped thin-walled vessels and stellate cells. Local excision is all which is required. Positive stains, Desmin, Vimentin, ERPR. Differential diagnosis like angiomyofibroblastoma, angiomyxoma, sometimes rhabdomyosarcoma if it is very cellular, or a cellular angiofibroma. Then pseudosarcomatous fibroepithelial stromal polyps. Here also the differential diagnosis are too much. Why pseudosarcomatous? Because of frequent mitosis. And the margin status here, as I will say further when I come in later slides, that the vulvectomy specimens, you have to give the margins and all. So that is very important in this. Then this entity, again, the mesenchymal lesions only, superficial angiomyxoma, cellular angiofibroma, superficial myofibroblastoma, angiomyofibroblastoma. So I will discuss little bit in detail about them, like aggressive angiomyxoma, also called as deep angiomyxoma, first described in 1983 as aggressive angiomyxoma of the female pelvis and perineum. Rare, locally aggressive, infiltrative mesenchymal tumor of unknown etiology. When I show you the WHO classification, these entities will all reflect, and this is included in the uncertain category. It is called aggressive due to neoplastic nature of the blood vessels, locally infiltrative behavior, and high risk of local recurrence. HMGA2, formerly known as HMGIC, located on chromosome 12q15, is often rearranged in aggressive angiomyxoma, resulting in aberrant HMGA2 protein expression. So this is the update in aggressive angiomyxoma. This is the gross description. Tumor size ranges from 5 cm to more, can appear as a polypoidal mass. External surface is smooth and usually not encapsulated. Tumor tenaciously sticks to the knife. Angiomyxoma, the nomenclature. Usually presents as a painless swelling, mainly diagnosed on histological features. Prognostic factors, local recurrence, high risk of local recurrence, and complete excision is difficult due to infiltrative margins. Microscopically, spindle and stellate cells with myxomatous degeneration Unusual features include foci of increased cellularity and more fibrous stoma. The positive stains, smooth muscle actin, muscle-specific actin, CD34, Specimen, Vimentin, ER and PR, and nuclear HMGA2. Differential diagnoses are many, like all the myxoid lesions and angiomyofibroblastoma, Bartholin gland cysts, and botryoid rhabdomyosarcoma. These are all the differential diagnoses. In the cellular angiomyofibroblastoma, females of reproductive age, size, vagina, vulva. It's a benign tumor. Treatment is local excision. This is the microscopic description: circumscribed tumor with hypercellular and hypocellular areas. Mast cells are common in this, rare or no mitotic figure. Positive stains, as it is a mesenchymal lesion, I have said, Vimentin, Desmin, ER, PR. Negative stains, actin, because it is not a epithelial lesion. In electron microscopy, well-developed rough endoplasmic reticulum, Golgi apparatus, intermediate filaments, and pinocytotic vesicles. Differential diagnosis: angiomyxoma, cellular angiofibroma, and fibroepithelial stromal polyps. Then angiofibroma. It occurs in women aged 39 to 50 years. It resembles Bartholin gland cyst sometimes. Grossly less than 3 cm. Microscopically cellular, composed of gland spindle cells with brisk mitotic activity. Vimentin positive, negative for other markers. Differential diagnosis: aggressive angiomyxoma, angiomyofibroblastoma, leiomyoma, perineurioma, solitary fibrous tumor, spindle cell lipoma. For that, we have to resort to ISC if there is confusion in that. Then some tumors which occurs intraepithelial, like seborrheic keratosis, as you know, with characteristic second appearance, with horn cells, pseudohorn cells, acanthosis, and interlacing pigmented epithelial strains. And hydroadenoma papilliferum, I will be describing few adnexal lesions later, and the squamous intraepithelial lesions. This I will be covering in detail. Then condyloma acuminata, genital warts, a sexually transmitted infection caused by human papillomavirus infection. Sites are vulva, vagina, and see the characteristic morphology, very important in exam slides. Clinical features are flat, dome-shaped, keratotic, pedunculated or cauliflower-shaped. Biopsy only recommended when lesions are unresponsive to therapy. There is treatment for that, like podophylotoxin, surgical excision required sometimes, and microscopically, as I have shown, with acanthosis, disc keratosis, parakeratosis, hyperkeratosis, and the prominent granular layers with perinuclear cytoplasmic halos with retinoid pyknotic nuclei and coelocytosis due to HPV infection. Then some glandular lesions like Paget's, Bartholin gland carcinoma, eccrine spiradenoma, papillary hydradenomas, and pharyngoma. Like some of the things are overlapping because Bartholin gland carcinoma, it will come in the malignant lesions, and papillary hydradenoma, it will come in the adnexal lesions. So when you write the answer, this thing should be kept in mind. Paget's disease, intraepithelial neoplasm of epithelial origin, expressing apocrine or eccrine glandular-like features, and characterized by distinctive large cells with prominent cytoplasm, referred to as Paget's cells. So this is important new thing which has come across. Based on the origin, classification schemes have been proposed. Like type 1, primary vulvar cutaneous origin; type 2, secondary to primary anal or rectal adenocarcinoma; type 3, secondary to urothelial carcinoma. Diagnosis: must be confirmed by histology. Prognostic factors. Following histological features are associated with tumor progression and invasion, like increased expression of p53, combined expression of cyclin D1, and increased Ki67, reduced expression of E-cadherin. Treatment: microscopic surgery, radiotherapy or carbon dioxide laser ablation, and trastuzumab. This is an adnexal tumor with eccrine differentiation, eccrine spire adenoma, well circumscribed, round oval cell nest, blue balls in dermis, in organoid pattern of arrangement. Another adnexal lesion, the mesopapillary hydrandenoma, benign, small, sharply circumscribed nodule covered by normal skin. Papillary hydrandenoma. And basal cell carcinoma. Basal cell carcinoma, 2 to 8% of all vulvar malignancies, occurs in women more than 60 years of age. Chronic vulvar irritation. Other factors include ionizing radiation, arsenic, chronic inflammation. Molecular alterations are activation of the Hedgehog signaling pathway, leading to overexpression of GL12 or GL12 gene product, loss of function of PTCH1 or PTCH2, activating mutations of SMO and P53 mutations. It is not related to HPV infection. Prognostic factors: early diagnosis and complete excision are the most important prognostic factors, and the margins have to be reported. Incomplete resection with positive margins is common with the infiltrative, micronodular, and morphiform types of BCC. Presence of perineural invasion can predict local recurrence. This is the gross and microscopy. As I have said, there are various types of BCC as you see in skin, and all can be present in the vulva or the vagina. Positive stains: HMWCK, BRCA4, BCL2, P53, P63. Negative stains are EMA and CEA. Differential diagnosis are many. Histological differential diagnosis include adnexal tumors like desmoplastic trichoepithelioma and trichoblastoma. Then Bartholin gland carcinoma, another entity, and the carcinoma here isn't occurring in the Bartholin gland, but this could be a squamous cell carcinoma or adenocarcinoma or adenoid cystic carcinoma or any other variant. So you have to exclude metastasis from a genital or extragenital site before labeling it as a primary Bartholin gland carcinoma. There is a strong association between HPV and squamous cell carcinoma of the Bartholin gland. This is a microscopic description. There are various types like squamous, adenoid cystic, and the IHC is also different for each entity. Tumor size and stage are the most important factors, and treatment is surgical excision. Positive IHC stain, as I said, depending upon the type of the tumor, like if it is squamous cell carcinoma, P16 is positive, CK56, P40 and P63. If it is adenocarcinoma, it is CEA and CK818. Then adenoid cystic carcinoma, negative stains are adenocarcinoma P16 because it is positive in the squamous cell carcinoma. Adenoid cystic carcinoma show chromosomal rearrangements also. This is the sample pathology report. When you report a Bartholin gland, invasive squamous cell carcinoma consistent with Bartholin gland carcinoma, but then this squamous cell carcinoma shows strong diffuse P16 immunoreactivity consistent with it being associated with high risk HPV. The clinical setting location of the tumor mass and uninvolved overlying vulvar skin is noted. So this should be specified. These are the complete WHO classification of the tumors of the vulva. Because I have been covering them little bit of each, but then this is to write the answer, it is important that we know the classification very well. And this is the AGCC staging of the vulvar neoplasm, the TNM, the tumor size, the regional lymph nodes and distant metastasis with the stage grouping. After that, the squamous cell tumors and the precursor lesions, low-grade squamous intraepithelial lesion, it represents the clinical and morphological manifestations of a HPV infection with mild parabasal hypercellularity and coelocytotic atypia. Then high-grade squamous intraepithelial lesion, cells have enlarged hyperchromatic nuclei as you can see in the photomicrograph, with irregular nuclear contours and increased NC ratio. P16 immunohistochemistry is used and it is positive. In the differentiated type of vulvar intraepithelial neoplasm, here P16 is non-block positive. That means it is not associated with a human papillomavirus infection. And the extramammary Paget's disease, again, because I have seen in detail, I have covered that, the primary Paget's disease of the vulva. So again, to reinforce that, because IC is helpful for the primary Paget's disease. CK7, GCDF P15, CEA, HER2 and GATA3 is positive in this. Differentiated type of vulvar intraepithelial neoplasia. This lesion is HPV negative, occurs in elderly women, associated with lichen sclerosus and lichen planus, and is often associated with keratinizing carcinoma. High-grade squamous intraepithelial lesion, as I have already described earlier. Then the squamous cell carcinoma. Most common vulvar malignancy, most common in elderly, most important factor determining the outcome is the lymph node status. Most important factor determining lymph node metastasis is depth of invasion. Two main morphological types, keratinizing squamous carcinoma and basaloid squamous carcinoma. So it's an invasive epithelial tumor composed of squamous cells of varying degrees of differentiation. It may or may not be associated with HPV. HPV positive tumors are often basaloid. Tumors are usually HPV 16 and P16 positive. Squamous cell carcinoma. So some questions which have to be answered to break the monotony is that this is a high-grade squamous intraepithelial lesion of the vulva, which is the IHC used for differential diagnosis against differentiated vulvar intraepithelial neoplasia. The answer will be P16 because they are P16 negative. Then block pattern in high-grade squamous intraepithelial lesion, P16 positive. Then which IHC shows an aberrant mutated pattern in differentiated vulvar intraepithelial neoplasia, it is P53. Then this is the HPV independent squamous cell carcinoma of the vulva in association with differentiated vulvar intraepithelial neoplasia. Which gene is important? It is P53. Then staging of carcinoma of the vulva. So depth of invasion is a critical parameter for grading early stage vulvar cancer. Depth of invasion of more than 1 millimeter in a tumor confined to vulva qualifies as stage 1B disease. And most important tumor related feature for staging early vaginal carcinoma is tumor size. And which of the following is true about the squamous cell carcinoma of the Bartholin gland? It is associated with human papilloma infection. After that, the melanocytic tumors. I will touch upon the melanoma in detail. There are atypical melanocytic nevi of the genital type. It's a nevus of special site. Terminology is nevus of milk-line type. Occurs in vulva of young women. Treatment is local excision. Molecular description, BRAF mutations are found in this. Histological patterns are nested. This has a nested pattern, crowded pattern, or a junctional melanocytic proliferation. This is the atypical genital nevus, more photomicrograph. Melanocytes are epithelioid to ovoid, and core cytoplasmic melanin pigmentation is often identified. Then vulval melanoma, large and ulcerated tumor with bluish, black to brown coloration, sometimes with clear cell change. As you know, a melanoma is a great mimicker. It can be seen in any form. 4 to 10% of all vulvar malignancies. Patients are usually 58 years or younger at diagnosis, have a better prognosis. Breast load, depth, it is tumor thickness, and feasibility of complete resection with appropriate margins. Ulceration is also a feature now because as per the AJCC CNM, ulceration is a criteria and it's a prognostic indicator. Margin status, free margin of more than 1 millimeter associated with better prognosis. Strong and diffuse C-kit excretion may be associated with worse prognosis. Then histological type, you see like the Clark level, breast lobe thickness, as you see in, at any other site. HE stain, melan A, and soft stain is the new marker for melanoma. And the tumors of vagina, again the subgrouping. You name the tumor and you see here, but the subgrouping as per the WHO, it should be accurate. Some of the lesions which are common, like adenosis, cysts, papillomas, then glandular tumors. Then the AJCC staging, TNM, and stage grouping of the vagina. In vagina, the low-grade squamous intraepithelial lesion, flat surface lesion in which the lower third of the epithelium contains a distinct basal cell, whereas the upper third is occupied by occasional cells with double nucleation, coelocytes, and surface parakeratosis. High-grade squamous intraepithelial lesion, this is a colposcopic image. It carries a significant clinical risk of invasive cancer development if not treated. Then squamous cell carcinoma. It could be NOS, keratinizing, non-keratinizing, papillary, basaloid, warty, verrucous. So, when you receive a vulvectomy specimen, you will receive with margins. Surgeons will specify with the sutures, the margins. And you see here the clockwise. The crossing has to be done clockwise, and margins, the soft tissue margins, they have to be given, and the vulvectomy margins has to be given. Then the section from the lesion and the uninvolved normal skin surface, that has to submit it. So features to report are specimen type, procedure, tumor site location, tumor focality, tumor size, histological type and grade, thickness of tumor, depth of invasion, tumor growth pattern, margins, lymphovascular invasion, lymph nodes, distant mets if any, pathological staging, and presence of vulvar intraepithelial neoplasia. This makes a complete report for a vulvectomy specimen. In vagina, anatomic site and location, size, depth of invasion, histologic type, histological grade, pagetoid spread, type of invasion, angiolymphatic invasion, adjacent organ involvement, margin, presence of VAIN, condyloma acuminatum or adenosis, any ulcers, then lymph node involvement. If adjacent tissue is involved. So, as I have described earlier, pathological staging is based upon the largest lesion or lesion with the greatest depth of invasion will determine the T stage. This is just a repetition to reinforce that the staging has to be done. AGCC Cancer Staging, 8th edition and the FIGO 2018 update. And the stage grouping. That was for vulva and this is for the vaginal carcinoma. TNN staging with stage grouping and FIGO stage. Thank you.
Oh, wonderful. Very nicely done, ma'am. Excellent. And exactly what is required for postgraduates. You have handled it very nicely. And every aspect of vulva vagina, starting from the basic benign lesions, fibroepithelial polyps, to pre-malignant as well as malignant conditions, as well as the TNM staging, especially the 8th edition in which minor changes have taken place, and even the grossing has been taken care of. Wonderful lecture, ma'am. Thank you so much. If there are any questions, we will take some questions if there are any.
Yeah, because my aim is like, first of all, the grossing, and second, it should be complete answering itself. Like when you get a full question or a long question to write, it should be complete and you'll be able to write it like that. Right. And the slides also, slide-based thing is there. And some questions were asked to break the monotony of the lecture.
Correct.